So the first half of this, a lot of you are probably very familiar or bordering on board with calcification morphology and distribution, as well as morphology-based path concordance when we biopsy those. So I will try to go through that relatively quickly so that we can focus our time on some interesting cases, dive a little more into calcifications on digital breast tomosynthesis, or DBT, which Emily gave us a great intro on, and then some cases at the end. So why is this significant? Why are we focusing so much on calcifications? If we look at the literature, the range of cancers that are detected primarily or solely based on calcifications is all over the place, 13 to 41%. So they're important. There's a lot of cancers that are just calcifications. Among DCIS diagnosed by calcifications, actually a low percentage, less than 20%, are low grade. This is really important. We keep hearing about overdiagnosis, and DCIS keeps taking the blame for that, calcifications, but really it's a minority at detection that are low grade. Unfortunately, though, it's still not possible for us to radiographically distinguish low from high grade, i.e. on imaging, we can't really tell which ones are clinically relevant, and if they're not, when, over the next few years, they might become clinically relevant. Perhaps AI can get us there at some point, but we're not there yet. And 1/3 of cancers detected on the basis of calcs alone are invasive. They're smaller, but they are no less biologically aggressive in terms of grade, receptor status, et cetera, than the cancers that are detected without calcifications. So, therefore, are they a missed opportunity? Well, there's a good retrospective study. It's out of the Netherlands. We have to take that with a grain of salt when we're comparing it to how we screen in the US, because they're screening every other year, and they also have a very, very low recall rate compared to us in the US, around 2.5%. But what they found was that 46% of screen-detected cancers had calcifications at the time that they were diagnosed. And then when they looked back on the prior mammogram, so again, this is a little different, most of the priors are 2 years ago, over half were detectable. They used a combination of CAD and a radiologist to make that determination. They were detectable on the prior negative mammogram. And so they came up with a sensitivity of the calcifications, about 45%, fairly low. They also noted that about 68% of the cancers were detectable calcs on the prior mammogram. They were invasive at the time of diagnosis. So again, all pointing to the importance of calcifications and really showing us that we don't know which calcifications are overdiagnosis at this point, but a lot of them are clinically relevant. The challenge here, of course, being that the percentage of biopsied calcifications, if you look from study to study, it ranges all over the place, really broad range, but 30 to 87% of biopsied calcifications are benign, which is why they continue to trouble us. So they're tricky, but clinically relevant, right? So now we're going to briefly go over the assessment. Again, this is familiar to most of you. You know to assess both the morphology and the distribution. The number of calcifications is, of course, less important than the morphology and the distribution, and we want to judge them and name them when we're using BI-RADS by their worst feature. So BI-RADS 4, 4th edition had them grouped into 3 groups. Now, of course, BI-RADS 5 has them more in 2 groups, so typically benign, that's skin, coarse, dystrophic, vascular, large rod-like, and rim, and then a second category of just suspicious. In my head, I tend to think of the lower suspicious ones as amorphous and coarse heterogeneous, on the range of 10 to 20% chance of being malignancy, and then the higher ones, fine pleomorphic, fine linear branching. Of course, the poor punctate calcifications are sitting down here by themselves because they're really sort of it depends, there's more to it. Then when we combine the morphology with the distribution, BI-RADS 5th edition shows us that we can really break down the level of suspicion even a bit more. So for those of you who choose to subdivide category 4 into 4A, 4B, and 4C, 2 to 10%, 10 to 50%, and 50 to 95% chance of malignancy, respectively. You can use the morphology combined, of course, with the distribution to sort of hone in on the level of suspicion. Of course, fine linear branching are so suspicious that regardless of the distribution of those, they will be at least a 4C. So let's now just quickly run through the examples of the calcifications. So typically benign, we have skin calcifications. I'm not going to spend much time on this at all. Emily did them justice, and you've seen how tomosynthesis can really help localize them to the skin so that we don't need to do nearly as many tangential views as we used to do. But even without good imaging, we already start to suspect that they are skin calcifications based on location. So you'll see these tiny groups or clusters along sort of icky, sweaty places like inframammary fold, peristernally, and axilla. Here, again, you can't even see the morphology, but you can see that these are great locations for dermal or skin calcs, medially on the CC here, inferiorly on the MLO. I have a feeling some of these really tiny microcalcs aren't going to be so great, but we'll see. Next, typically benign, the rim, or what used to be called eggshell. Wide range in the size of these. You guys are all familiar with these. Smooth surface, lucent center usually, although as they progress, they can really fill in, get some chunkier calcifications in the middle of them. That's because these are often fat necrosis or oil cysts, or occasionally just regular old benign cysts that calcify on the rim. So they are easy to diagnose, usually very classic. Next, vascular calcifications. So these are easy in most cases, tricky to discern and to classify in some cases. So when they're nice and classic, they have parallel tracks or linear calcifications that you can associate with tubular structures. Emily showed us on tomosynthesis that can actually help us categorize vascular calcifications as such because we can see that tube when we tomo through. They can be fragmented, and early vascular calcifications, such as the portion that you're seeing in the pink box, if you just had that alone, that would be slightly harder to classify as vascular, while those two parallel lines are still filling in with calcifications. In some cases, it's really tricky, and we wind up having to do a biopsy because we can't tell if calcifications that are in a linear distribution are vascular or not. So here's a patient who obviously has a history of left breast conservation therapy or lumpectomy. She's had robust scarring and fat necrosis with dystrophic calcifications. And oh boy, I wonder if you'll be able to see this at all. But there's a nice red arrow sign. So there's some very, very fine branching linear dots of calcifications. To me, they kind of look like dot dash, and I'm going to really zoom in here and hope that you guys can get some sense of them. If not, please take a look at Jordan is giving me a thumbs up. It's awesome. So she's in the front, but she's at least seeing something, so that's good. So there are these little dot dash calcifications in several areas that look different from these bigger calcifications, and I'll tell you some of these are actually probably secretory and some are vascular. She has both in her breast, which is also a confounder. So I took her to tomosynthesis for biopsy. Now, I know some people, the very fine calcifications, prefer to do old school 2D stereotactic biopsy. I actually find that tomosynthesis works really well if I do a breath hold on the initial view to see the calcifications, and I actually prefer to biopsy them. Now, in this case, I really wanted to biopsy them under tomosynthesis because I knew that she had some neighboring vascular calcifications, and I wanted to use the tomosynthesis to try to make sure that I was focusing in on the ones that I was worried about rather than the vascular ones. So I biopsied them under tomo, and you can see here, even on this little zoomed view, she has different morphologies of calcs, right? She's got some that are likely vascular, she's got some that may be secretory, and these guys are the ones, that dot dash, and they're even branching a little bit, that are more worrisome. And sure enough, that was grade 3, high grade DCIS, so hard to see, but high grade. Moving on, typically benign, these are often classic, are large rod-like calcifications or secretory. They are just simply associated with ductal ectasia. They are common as we age. They're often bilateral and easy to diagnose that way. When they're tricky is when they're just starting to form, so they may be unilateral and just in a small area. Next, in the typically benign, is coarse or popcorn-like calcifications. These are large, chunkier, so we need to think of these as being larger and chunkier as their friend and more suspicious calcifications, coarse heterogeneous. They are typically produced by an involuting fibroadenoma, so we often tend to see these around perimenopause and later as fibroadenomas tend to involute as hormones change. It's helpful if you can see a smooth soft tissue mass or focal asymmetry around it, but we don't always see that. When we do see the classic here, you can see that nice soft tissue asymmetry around it, and these are so chunky that none of us would question this. This is easily popcorn calcifications from an involuting fibroadenoma. However, early in the process of involution and calcifications, that's when it can be a little bit tricky, and we may wind up watching the calcifications or biopsying them. So you can see here on our baseline, we have a mass, and there is 1 or 2 punctate calcifications forming. 4 years later, it becomes easier to identify. While there's still a paucity of calcifications, we have at least one nice chunky coarse calcification to suggest that this is in fact an involuting fibroadenoma. At 6 and 7 years later, respectively, there's even more, and it has declared itself. Next is milk of calcium. So this is, of course, sedimented calcifications that's in either macro or more typically teeny tiny little microcysts. They're amorphous, round, or punctate on CC views. It just depends. They're sitting basically in the bottom of the little acini cups. They're more clearly seen on the 90-degree lateral because that's what allows them to settle out into the little semi-lunar shapes or crescents as they settle toward the dependent part of the microcyst. And what's also helpful sometimes is even if you don't see clear layering, you can appreciate that they change shape a bit. They can go from amorphous on CC and really kind of crisp up on lateral views. So even if you're not seeing that straight lateral, that crisping up can really help you determine that that is most likely what you are looking at. So here's a nice example on CC. Here she has a few round and amorphous calcifications. Not only do they change shape, but all of them crisp up. So those few that were amorphous are now more easily seen. You're going to notice they're never all going to layer perfectly right. We just need a sampling of them to do that. If you suspect that they are milk of calcium and they are not layering, then I like to do what we call a delayed view. So put the patient in the straight lateral view, either the full breast straight lateral view or a magnification view, and make that poor patient stay like that for a minute or two. And the calcifications will layer very many times, and sometimes you'll even see that when you take them to stereo or tomobiopsy. If you biopsy in that position and you leave them for a minute before you do the biopsy, you can sometimes even cancel it. I promise I did actually check that. I tested that 2-minute delay on myself to make sure it wasn't too absolutely unbearable. It's not fun, but it's okay. Here's another example where it's a little bit tricky sometimes to tell the milk of calcium, so you might be able to see here she has diffuse